This presentation is about Medicare ACO REACH, formerly called direct contracting, and I'll be speaking as to why this is a threat to seniors, people with disabilities, and the future of Medicare. My name is Linda Phenix, and I'm a member of the Houston chapter of the Texas Alliance for Retired Americans. I co-chair the Texas Task Force to Protect Medicare from Privatization. I'm a member of Physicians for a National Health Program, which for over 30 years has been the leading advocate organization for a single-payer national health insurance program. I'm also a member of National Single Payer, now in its second year as a national grassroots organization, also focused on national single-payer healthcare. My career was in the performing arts, and many of my artist friends struggled for years to afford and or qualify for health insurance. This is what initially drew me to be an activist for healthcare justice. And like most Americans, I've heard countless health insurance horror stories, including in my own family. Many of us believe that traditional Medicare is a pillar in our healthcare system. However, traditional Medicare is now a target for privatization by the ACO DCE REACH program and those who promote it. This threat to Medicare must be taken seriously, and President Biden could end it with the stroke of a pen through executive action. To understand DCE ACO REACH, I will start with a brief history of why we got Medicare and the decades-long drive by the U.S. Congress and Executive Office to privatize it to varying degrees. This is the first Medicare card that was issued. It was to President Harry S. Truman. And in 1945, President Truman had called for the creation of a national health insurance fund open to all Americans. 20 years later, his dream was still unrealized. However, President Lyndon Johnson was successful in getting Medicare for seniors enacted into law in 1965. What led to this? The insurance industry did not want to insure the elderly. Before Medicare, only 60% of those over 65 had health insurance since it was unavailable or unaffordable. Seniors were charged 3 times the rate of younger people for health insurance. The passage of Medicare benefited impoverished seniors and the working class, but it was also a huge civil rights victory as payments to physicians, hospitals, and healthcare providers was contingent on desegregation. While Medicare was a big victory, it did not provide full coverage for all services, and that created a hole in the apple for for-profit seeking commercial insurers to worm their way into Medicare. 2022 was the 50th anniversary for for-profit health insurance corporations participating in Medicare. But it's important to understand that the U.S. Congress and the Executive Office have also promoted commercial insurance participation of Medicare. Here are some highlights. The Nixon administration opened the door for HMOs with the expectation that they would lower Medicare's costs, which they did not do. In 1997, President Clinton introduced the choice plans, which were the precursors to Medicare Advantage plans. Choice plans were supposed to lower costs, which they did not do. Privatization was boosted significantly under the George W. Bush administration by the Medicare Modernization Act of 2003. This paved the way for more health insurance companies to enter Medicare and label their plans Medicare Advantage. The Obama administration passed the Affordable Care Act, further cementing commercial health insurers into our healthcare system. The ACA legislation also included the development of the Center for Medicare and Medicaid Innovation, CMMI, which has the authority to develop pilot programs with no congressional oversight. Under the Trump administration, a former dorm mate of Jared Kushner's was made head of the CMMI, and he was responsible for the agency developing a new pilot program called Direct Contracting, or DCE. And under the Biden administration, Trump's DCE program was rebranded as ACO REACH. The DCE ACO REACH programs are nothing more than wealth-creating business models that will further drain the Medicare Trust Fund. These companies will maximize profits and satisfy shareholders, not the public. The targets are seniors and those with disabilities who enrolled in traditional Medicare. This is a good visual to show who will be targeted by the DCE ACO REACH program. So in the top bar, we have traditional Medicare beneficiaries, and that's where the government just pays providers, physicians, hospitals directly. The bottom bar are the Medicare Advantage programs or commercial insurers. This basically means that Medicare is pretty much privatized right now by about 50%. But the ACO REACH programs, they're focused on that top bar, that light blue bar, traditional Medicare and traditional Medicare beneficiaries. This is who they want to target. So in rebranding DCE to ACO REACH, CMMI made a big deal about the new program's incentives to improve health equity. REACH stands for Realizing Equity and Community Health. Who could be against that? But these equity incentives may encourage REACH middlemen to profiteer in underserved communities. This is because Medicare will give the middleman an extra $360 per year for each senior who is considered underserved based on residence and income. And Medicare is now allowing middlemen to use demographic factors like race and income to increase enrollees' risk scores to get increased payments from Medicare. I'll be talking about that in some upcoming slides. So middlemen are also required in these programs to submit a so-called equity plan. This is not a part of their application, but after they've been approved. And this so-called plan is submitted on a pre-printed worksheet. I've seen that worksheet and it looks like something a fifth grader would complete for an assignment. And the Centers for Medicare Services will not use that plan to hold the company accountable for improving care. So it's not really clear why they have this plan in the first place. So what is ACO REACH? Well, we've learned that it came from the Trump administration, then called DCE, rebranded by the Biden administration. But essentially, this is what it is. Instead of paying doctors and hospitals directly, Medicare gives third-party middlemen called ACO REACH entities a monthly payment to manage seniors' care, allowing the companies to keep as overhead and profit what they don't spend on medical services. How is ACO direct contracting different from traditional Medicare? Well, in traditional Medicare, Medicare pays providers directly for patient care, so that's pretty straightforward. But in direct contracting, Medicare pays DCEs, ACO REACH companies, a set amount each month to manage patients' care. So they are a middleman between Medicare and your provider, and between your provider and you. How could such a radical change to traditional Medicare happen completely under the radar? Well, we've talked about direct contracting coming from the Centers for Medicare and Medicaid Innovation. This is an obscure agency within the Department of Health and Human Services. It has the power to implement pilot programs to all of Medicare and Medicaid and scale them up without congressional approval. CMS will approve any program if it believes it will reduce spending without decreasing quality, or improve quality without reducing spending, and it does not deny or limit coverage or provision of benefits. So under the HHS is, of course, the CMS, and then here comes the under the radar program, CMMI. And this, of course, was established by the Affordable Care Act, which we talked about. And the ACA funded CMMI with $10 billion from 2011 through 2019, and another $10 billion for each decade after that. These funds are not subject to the appropriations process, so this little known agency has tremendous power and substantial resources. Now that we've peeked under the hood at the agency responsible for the program, let's look more closely at these companies and the people behind them. Even though it's called a pilot program, DCEs already operate in most states in the US. So the direct contracting program ran until December of 2022 with 99 DCEs participating. Now those DCEs are not going away. They will likely be grandfathered in as ACO REACH companies in January of this year. We can expect hundreds more direct contracting companies to be operational across the country. And virtually any type of company, regardless of healthcare experience, can apply to be a DCE or ACO REACH entity, including commercial insurers and venture capital investors, and applicants are approved without input from Congress. So in review, we went from traditional Medicare, where Medicare pays doctors and hospitals directly, to a direct contracting model where we inserted a middleman between Medicare and providers. But there's another set of players that are even more important than the DCEs, which are the Wall Street investors who fund the DCEs and the ACO REACHs. And they're flooding these companies with new money. These investors aren't stupid. They only put their money where they expect big profits. So how does a company with the stated goal of improving care and saving money make a big enough profit to keep investors happy? How do ACO REACH entities make money? Maximize the revenue they get from Medicare, minimize revenue spent on patient care, and enroll more beneficiaries. First, let's look at the money coming in and how they maximize revenue. Upcoding. By making seniors look sicker than they are, REACH entities can get higher monthly payments from Medicare, regardless of how much care patients actually receive. Medicare Advantage insurance companies have been inflating patient health conditions and risk calculations for years. So I think we know what to expect from the DCEs and ACO REACH companies. What does upcoding look like? First, let's see an example from a 76-year-old female with some common diagnoses. Each condition gets a score, and the total score determines how much money Medicare pays the DCE or the REACH each month. Remember, this has nothing to do with actual care provided. It's just a description of conditions. Now let's look at, and let me just say, for this first slide on the left, the DCE or the ACO REACH would be paid $9,000 from Medicare. So now on the right, we're looking at what happens with upcoding. Morbid obesity, obesity becomes morbid obesity, diabetes now has retinopathy, congestive heart failure is class 3, COPD, and so on. And because of those bigger risk scores, Medicare must now pay the ACO REACH a whopping $32,000 regardless of the care provided. This is a reminder that the detailed coding may not represent this patient's current medical status. On October 8th, 2022, the New York Times published a bombshell, an investigative piece about the Department of Justice going after fraud in Medicare Advantage. These are some of the highlights. Last year, DOJ Civil Division listed Medicare Advantage as one of its top areas of fraud recovery. 8 of the biggest Medicare Advantage insurers, which represents more than 2/3 of this market, have submitted inflated bills according to federal audits. The government now spends nearly as much on Medicare Advantage's 29 million beneficiaries as on the Army and Navy combined. This is enough money that even a small increase in the average patient's bill adds up. The additional diagnoses led to $12 billion in overpayments in 2020, but one former top government official suggested the overpayments in 2020 were more like $25 billion. And this is also from the New York Times article, a chart with the top 10 Medicare Advantage providers. Look at all the check marks being accused of fraud by whistleblowers or the government or the inspector general. This is a particularly stunning slide. This is Medicare Advantage overbilling. It exceeds entire agency budgets of NASA, of the CHIP program, U.S. Customs, Border and Protection, and on and on. What is CMI doing about this? Well, in September 2019, Kaiser Family Foundation filed suit against CMS, accusing the agency of improperly withholding the audits of Medicare Advantage plans for the years 2011, 2012, and 2013. The 90 audits are the only ones that this agency had completed over the past decade, a time when Medicare Advantage had grown explosively. Enrollment in the plans more than doubled during this period, passing 28 million in 2022 at a cost to the government of $427 billion. I would note that the Centers for Medicare and Medicaid Services agreed to release the records to settle this lawsuit. So why are we focusing on Medicare Advantage? What does that have to do with ACO REACH? Well, to understand direct contracting and ACO REACH, it's important to understand that the first wave of Medicare privatization is through Medicare Advantage. The next phase of Medicare privatization is direct contracting, which will further privatize traditional Medicare by using some of the same elements as Medicare Advantage. The direct contracting business model is like the Medicare Advantage business model. DCE will increase their capitation payments and decrease expenses by spending as little as possible on care. So just a refresher about what the Medicare plans have been doing to increase profits besides with upcoding. It all falls under minimizing expenditures on patient care. They'll seek healthy patients that don't use a lot of services. They limit care for expensive conditions, limit networks of doctors, don't cover hospitals needed for expensive care, and they delay and deny treatment. Those are hallmarks of the Medicare Advantage plans, which also means worse health outcomes and an increase in premature death. I would also note that the Mayo Clinic has stopped accepting patients with Medicare Advantage plans and is encouraging patients to enroll in traditional Medicare. Congress favors Medicare Advantage. The federal government has allowed for perks in Medicare Advantage plans, the free gym membership, some limited dental and vision care, reduced premiums, and these benefits are not available to those choosing traditional Medicare. So you can understand why the efforts by some in Congress to add dental, vision, and hearing benefits to traditional Medicare have been denied. And Medicare Advantage companies also increase enrollment with these perks, which means they can offer lower premiums as well, and this is made possible through the excessive payments they receive by upcoding. Now, ACO REACH entities, how do they make money? We're back to ACO REACH. They're allowed to keep as profit and overhead what they don't spend on medical services. This is a dangerous incentive to ration and restrict seniors' care. These financial incentives do not exist in traditional Medicare. Why should we stop the ACO REACH program? Because it threatens Medicare's solvency, the trust fund. It threatens seniors' health and healthcare choices. ACO REACH threatens Medicare's solvency, which is a fancy way of saying it will be bankrupting the trust fund. So while traditional Medicare spends 98% of its budget on patient care and 2% on overhead, REACH entities may only spend an estimated 60% of what Medicare pays them on patient care, with the possibility of keeping up to 40% as overhead and profit. To give you context, let's look at how DCEs compare to traditional Medicare. Medicare spends 98% on patient care, 2% on overhead. Now let's look at the comparison to Medicare Advantage. These are the commercial insurers. They're required to pay 85% of what they get from Medicare on patient care, keeping 15% as profit and overhead. But what makes it even worse for the DCEs and the ACO REACH companies is there isn't a similar arrangement. And it's estimated they will spend as little as 60% of the money they get from Medicare on patient care, keeping up to 40% on profit and overhead. This is an important slide. Up to 30 million seniors who actively chose traditional Medicare may be automatically aligned with a DCE REACH entity without their full knowledge or consent. How are they going to get people into their program? If a senior's primary care physician is part of a REACH entity, the Centers for Medicaid Services will automatically align the senior with that entity. They may get a form letter that looks like this, which most of us would toss in the trash, especially when we see this. No action required on our part. How does this happen? The Center for Medicare and Medicaid Services actually searches 2 years of each senior's claims history to see if the senior has gotten care from a DCE-aligned primary care physician. So when a senior is auto-aligned to their doctor's REACH entity, the only way to opt out is to change primary care physicians. And that means that senior will be looking on their own. This is especially difficult for seniors in rural or underserved areas. And asking seniors to change primary care physicians undermines traditional Medicare's promise of a free choice of provider. For many seniors, this is why they choose traditional Medicare over Medicare Advantage. So, how could this be happening? This is a radical transformation of Medicare, and it is by design. The Center for Medicare Innovation plans to expand ACO REACH to all of traditional Medicare within a decade. CMMI's goal is to move Medicare beneficiaries into some kind of accountable care for-profit arrangement, either into a REACH or a similar managed care model. This is just a reminder of the CMMI, this this agency under Department of Health and Human Services that has incredible authority, and it is attracting private equity and industry insiders to lead it. Who was responsible for the direct contracting scheme? This is Adam Baylor. He's a former dorm mate of Jared Kushner's, who was appointed director of the CMMI during the Trump administration. Prior to joining CMMI, he was founder and CEO of Landmark Health, a home health company, which later won a DCE contract. Before joining the CMMI, he divested from Landmark along with other health-related investments. During his tenure with the CMMI, which wasn't really very long, he contracted with a company called Oxeon. And he had Oxeon recruit non-career staff for the CMMI with the purpose of designing the DCE pilot program. Baylor's former company, Landmark Health, was backed by venture capital money, including this firm, Oxeon, and multiple Oxeon-funded health companies, such as Oak Street Health, were directly referenced in documents setting up the new Medicare direct contracting project. This drew scrutiny from the Office of the General Counsel. In January 2019, ahead of the launch of this new program, the Office of the General Counsel for the Health and Human Services Department warned in comments on a draft of the proposal that it appeared as if this new project was being set up to benefit specific companies. This was reported by The Intercept in December 2021. So what became of Baylor after he left the Trump administration? He co-founded Rubicon Partners, which is now partnering with physicians to form DCEs and managed Medicare Advantage companies. So who was responsible for rebranding the direct contracting scheme? This is Elizabeth Liz Fowler. She is the former Vice President of Public Policy and External Affairs at WellPoint, the giant health insurance company that later became Anthem. Fowler was the Chief Health Counsel to Senate Finance Committee Max Baucus, and she played a critical role in the writing of the Affordable Care Act. She wrote the ACA reform policy to protect the future and the profits of the industry from which she came. In 2020, Anthem, her former employer, reported over $4.5 billion in net income. After Fowler left the Obama administration, she headed for the pharmaceutical industry as a lobbyist for Johnson & Johnson. She had senior positions in Johnson & Johnson's government affairs and policy group before coming back to work as Biden's head of the CMMI. Under Fowler, the direct contracting program was rebranded as ACO REACH. And Fowler continues to defend the program. She's openly advocating for the total privatization of Medicare. She wants all Medicare fee-for-service beneficiaries to be in a care relationship or ACO-like arrangement by 2030. So, just as a reminder that virtually any type of company can apply to be a DCE or ACO REACH entity, including commercial insurers. These are activists protesting in front of the Humana building in Louisville, Kentucky. Humana is one of the direct contracting entities that are privatizing Medicare. And New York Times reported in July 2022 that Amazon's joining the Medicare privatization scheme. The retail giant is deepening its presence in healthcare. Last year, it announced plans to acquire One Medical, a telehealth and primary care service with a network of 188 medical offices, primarily in large cities. In 2021, One Medical acquired Iora Health, which is a direct contracting entity. Even AARP is in on it. Questions about AARP's position on this program are asked by seniors each time this presentation is given. Actions speak louder than words. AARP has a paid partnership with the DCE. In September 2021, Oak Street Health announced a partnership with AARP. Less than 2 months after announcing the AARP, Oak Street revealed it was the subject of a Justice Department civil investigation into its marketing tactics, including whether it violated a federal law that imposes penalties for filing false claims for payment to the government. Oak Street Health has denied wrongdoing and says it is cooperating with the investigation. AARP has drawn intermittent scrutiny from its longtime partnership with United Health, which uses the AARP sale of approval to market its plans to seniors. This arrangement has brought hundreds of millions of dollars in annual royalties to AARP, according to court records. And the Justice Department's Civil Fraud Division alleges that United Health reaped $1 billion or more in illegal overpayments. The company has denied the allegations, and the case is set for trial next year. So IRS records basically show that AARP collects $1 billion annually, most from these health-related business arrangements that are eager to sell their wares to the group's members. AARP collects so much revenue that they can pay their CEO $1.3 million, as was noted in 2020. Now, efforts to stop the ACO REACH program have been ongoing and extensive. This is a sample. This is a PNHP physician-led delegation to the doorsteps of the Department of Health and Human Services. This was in the fall of 2021. These are some of the folks here on the right. They delivered petitions with 13,000 plus signatures demanding an end to Medicare direct contracting. Secretary Becerra has the authority to end this program. I would also say that these physicians met with congressional staff members and were very instrumental in educating them about this program. And elected representatives have been pressuring Secretary Becerra to cancel REACH, which again, he has the power to do. 54 members of Congress, all Democrats, sent a letter to him demanding an end of this program. This was about a year ago. Senator Elizabeth Warren held a Senate hearing in February 2022. And the efforts to educate Congress, the public, and the media have been extensive and are ongoing. The word is getting out. Of course, DCE and ACO REACH owners and investors are fighting back to protect their profits. Texas has a member of Congress who's been sounding the alarm about these programs, really going back to 2020. Lloyd Doggett, who was the former Ways and Means Health Subcommittee chair, was one of the first members of Congress to recognize that this program was a threat to Medicare. In May of 2020, he joined 3 other members of Congress calling for the end of this program. But this is a particularly powerful letter that he sent to Secretary Becerra and also to CMM Administrator Chiquita Brooks LaShore. She also has the authority to end this program. And I won't go through all of the nitty-gritty of the letter, but I will say that it is a powerful argument. It basically ties together everything in this presentation today. And he talks about how beneficiaries who selected Medicare coverage on purpose could face barriers of care with this program. He talks about incentivizing denials of care, dissuading people from seeking care. And this is particularly important. He addresses the fact that this will further privatize Medicare. It will increase healthcare costs and reduce quality of care. I really appreciate that he also points out the poor conditions this will create for healthcare workers. This is everyone from physicians, nurses, and other healthcare professionals who provide the care, but also it's administrators, it's people who work in the cafeteria, it's groundskeeper. Everyone is affected by these kinds of programs, especially because private equity will have a way into these programs, already does. And we're seeing what private equity is doing to our healthcare system, particularly the closing of hospitals around the country in rural and urban settings. Congressman Doggett points out that Wall Street does not belong in our hospitals, in our doctor's office. He also talks about 250 physician and consumer groups who signed an open letter. That's actually many more than this now. And then also the Texas Democratic Executive Committee unanimously adopted a resolution calling for the end of the ACO REACH program. This is what that resolution looks like. This is the Texas Democratic Party. And one of the items that they asked for, in addition asking the Biden-Harris administration to immediately stop and dismantle the program, they also want to protect and preserve traditional Medicare and add coverage for hearing, vision, and dental care. That letter that Congressman Doggett referred to is actually posted on protectmedicare.net. And these are amongst the alliances that have signed that letter. These are a list of the unions, labor councils who have signed on to that letter, which again is an open letter. And these are among the resolutions that are being passed against direct contracting and ACO REACH as of December 21, 2022. I would imagine there's many more of these around the country, but these are the ones that are posted on the protectmedicare.net site. So actions speak louder than words. These words, I can hear my mother saying this. And I would say that we cannot buy into the lofty altruistic characterizations by the Centers for Medicaid Services and the Centers for Medicare and Medicaid Innovation about the ACO REACH program or any other for-profit scheme for that matter. These agencies are participating in the federal government's creation of a system to privatize Medicare. We cannot buy into the bad actors paradigm if we just add some rules, more regulations, impose some fines. These are toothless actions because in truth, wealth creating business models have no place in our healthcare system. They exist to make a profit and will stop at nothing to maximize profits. We cannot be fooled by the altruistic language and business speak, value-based, accountable care, etc., that comes from for-profit health entities throughout our healthcare system, including in Medicare. We cannot wait to see what will happen with ACO REACH. It must be stopped now before there's nothing left to say. President Biden can end it with the stroke of a pen through executive action. So in 1965, President Lyndon Johnson was successful in getting Medicare legislation passed, and this was a small part of Harry Truman's dream to create a national health program for all Americans. Even so, Medicare was created to be a lifeline for America's seniors and those with disabilities, many of whom lived in poverty. They still do. Today, about 40% of older Americans rely solely on their Social Security income. Medicare was not intended to be a playground for Wall Street. The myth sold by privatizers is that inserting a middleman into Medicare will save money and improve care. It hasn't, and it never will. The privatization of Medicare must be stopped. The ACO REACH program must be stopped and eliminated. If Medicare is ultimately totally privatized, it will be a profound tragedy with repercussions we cannot fully comprehend. The book stops with President Biden, who often refers to himself as Joey from Scranton, the son of a working class father and the most pro-union president ever. So tell me, which side are you on, Joe? Which side are you on? The side of those draining the Medicare Trust Fund for profit, not services, or the side of the people? Labor is needed to play a central role in fighting the privatization of traditional Medicare by calling for the termination of the DCE ACO REACH program. And for everyone to learn more and to do more, go to protectmedicare.net. You can learn about the Medicare disadvantage, what is REACH, how to take action, and who are those protectors of Medicare. Thank you.